welcome to the NMI podcast, and we're speaking with Dr. Kirstie Lawton. And I'll give you an introduction before we get into the topic, which will be around a consortium of neurodegenerative disorders, including Motor Neurone Disease, Amyotrophic Lateral Sclerosis, well, some crossover in the nomenclature there, and Parkinson's disease as well as Huntington's disease. And for background, Dr. Lawton is an AFN registered nutritionist, a BANT registered nutritionist, a CNHC registered nutritional therapist, and has a career spanning over 20 years in the field. She obtained a BSc with honours in public health and nutrition and a PhD in nutrition from Queen Margaret University in Edinburgh, a diploma, so a DipION in nutritional therapy from the Institute for Optimum Nutrition, that's in Richmond, London, and a PGCE in higher education at the University of London to support her academic role, which we'll mention because it's really relevant. She's also completing an MSc in Neuroscience and Neurodegeneration through the University of Sheffield School of Medicine and Population Health. And in addition to her clinical work over the years, she was integral in establishing the UK's first level 6 graduate diploma in integrative functional nutrition at the Institute for Optimum Nutrition in collaboration with Portsmouth University, which was really developed for doctors, allied health professionals, and complementary healthcare providers to understand and incorporate functional nutrition concepts into clinical practice. She's a member of the editorial board on the NMJ, the Nutritional Medicine Institute's journal. And her interest is what we're going to speak about, and that's brain health. And it's based in her own experience with a seemingly undiagnosable range of neurological symptoms, which improved through diet, lifestyle, and nutraceutical support. And now her practice is really largely focused on the management of motor neurone disease, amyotrophic lateral sclerosis, Parkinson's, and Huntington's disease. So, no small introduction, Kirstie. It's a real joy to have you on this podcast. I'm really looking forward to speaking to you about this topic. You do stellar work in the area. I think it'll be really informative.
Thanks, Dan. Thanks a lot for that.
No problem. So I think a good place to start is how did you end up here? So you've got a fairly niche and unique clinical practice, I would argue, in a difficult area for many different reasons, in managing what are a collection of neurodegenerative diseases. How did you end up where you are today?
Yeah, I mean, it's been a long road, as you know. I have had a few different hats over the years, but it really started for me as a child. As you mentioned there, I had seizures as a child, both grand mal and petit mal seizures, and always had this diagnosis over my head. I didn't quite fit a box of epilepsy, so the diagnosis on my medical notes in North Norfolk in the 70s and 80s was epilepsy with a question mark that just followed me, through my childhood, and a mother who said, well, if you can't diagnose, you can't medicate. And so ahead of her time, and I sort of grew out of those seizures as I went into my later teenage years. And then I was living and working running a nutrition and dietetic department in the United Arab Emirates, and I'd been there around 6 years, and I started to have some resurfacing neurological symptoms that were potentially pre-Parkinsonian, particularly RBD, which is a sleep disorder. And I went to 5 different consultant neurologists, and no 2 could actually agree a diagnosis, but all 5 wanted to put me on clonazepam. And I remembered my mother, and I said, if you can't give me a diagnosis, you're not giving me medication. And I actually left the UAE and I came back to the UK in 2017 to really focus on healing my brain. And so, I'd been in the field of nutrition since the late 90s. My first degree was 2000 to 2004. And I'd started working pediatric nutrition around 2001. And so when I came back to the UK, having worked on my DipION and converted more from conventional nutrition over to a sort of integrative functional approach of nutritional medicine, I thought it was probably best to stay in the pediatric realm because I already had a lot of knowledge and I already had quite a good reputation. But on the sidelines, it was always about the brain and about Parkinson's and neurological health conditions. And I, did training with Lucille Leader, and I was listening to any podcast that became available, or reading every book out there, from Daru Purut and Broken Brain with Dr. Mark Hyman to David Perlmutter, to everyone that was talking about the brain. And so working in peds, I kept looking for different ways I could incorporate brain health and pediatrics. So I spent time working with neurodivergence, with mental health, eating disorders, and nothing quite felt like the right fit. And I was here with peds and over there was Parkinson's. And so eventually I just made the decision. I started seeing adults with Parkinson's, and eventually just in a very sort of much public way said I'm no longer really working with children and I'm focusing on neurodegenerative health. And again, at that point, focus was Parkinson's. As you mentioned, I sourced a master's in neuroscience and neurodegeneration at the University of Sheffield Medical School, which is actually, we've got the main MND centre there under Professor Pamela Shaw. And I had no intention of working with ALS or MND. And then I started to get a few clients, but still focus was Parkinson's. And then I had one lovely client, Claire, who's still doing really well, who came to the clinic and said, I'm working with a group in America called Healing ALS, and I want you to just guide me. And so, as you could probably understand, I sort of slightly rolled my eyes and thought, who are this group? And I logged on and I looked at the medical committee, and you've got like Dr. Lee Cowden, who is like globally renowned educator, has worked on so many protocols and is almost like a human AI bot with his knowledge. Like I've literally never met anyone like him. Diana Noland, author of Integrative and Functional Medicine, Nutritional Therapy, which was actually the book which was the recommended reading for my students on the grad dip. And Coco Newton, a dietitian who wrote that chapter on ALS for that book. So I thought, okay, I found my people. I found my little tribe, along with Tish and Scott, who set the organization up. And so I started doing lectures there and became part of the medical committee myself. And we all worked very closely together and very hard to drive that. And that's actually a non-profit. So it's for people who have ALS. So just with the definitions, it's amyotrophic lateral sclerosis, and ALS is the main form of motor neuron disease, but in the US people tend to refer to motor neuron disease as ALS. So I'll probably go back and forth, but when I'm talking about ALS, I'm talking about motor neuron disease today. So my practice is now probably 75% ALS, 15% Parkinson's, 10% others. Yeah.
Well, that's amazing. It's incredible that you were able to connect with that global community that are working in the space. Quite unusual. It feels like it must be a small global community, and a privilege to be part of that.
Yeah, a real privilege. And it's a role I take incredibly seriously, because I don't think you can work in ALS if you're not all in. You really have to be all in it and dedicated to it. And so I take my position very seriously.
Yeah, no, that makes a lot of sense. And I think for listeners, it'd be really useful because it is not necessarily within everyone's scope of practice or clinical experience. Can you give us a top line overview of the current thinking around these neurodegenerative disorders in terms of etiology and pathophysiology?
Yeah, absolutely. So there's some really well-researched factors that we see. I always consider them and say, yes, they are factors. They are things we've seen under the microscope. There is a lot of research on them, but we need to keep looking further to understand why these things are happening. So one factor is a genetic factor. So there 10% of people with Parkinson's and with ALS have familial types. So there's a number of different genes out there. So in Parkinson's, you've got like PINK1 and PARK2, critical for mitochondria quality control. So the mutations can lead to mitochondrial dysfunction and reactive oxidative stress. There's a gene called SNCA encodes for alpha-synuclein, which is the protein that's known to fold in Parkinson. So the aggregation of alpha-synuclein initiates oxidative damage, neuroinflammation. And that gene's actually partly governed by the gut microbiome. And there's other genes as well. There's a number of genes linked to Parkinson's. And then when we come to ALS, we've got the main genes, which are SOD1. So that's the encoder for superoxide dismutase. So, of course, that's one of the vital antioxidant enzymes, and mutations can disrupt the clearance of free radicals, driving up oxidative stress and inflammation. We've got a couple of genes as well that cause RNA dysregulation and lead to then protein aggregation in the cells. So that's C9orf72 and TDP43. And again, linked to mitochondrial dysfunction and calcium disturbances in the cells. And there's others as well. But I won't go through them all. Interestingly, a piece of research back in 2014, and we will come on to this because it's a really hot topic at the moment, is that those with mutations in the alpha-synuclein gene are more likely to be impacted if they've been exposed to pesticides. And again, that's about looking at, what do we know to be factors, but also what can potentially be driving those factors. And they're the sort of known genes, the familial genes. But so my master's dissertation year is next year, and I'm actually focusing on a couple of genetic variations that I'm seeing in my clinic. I'm seeing patterns in genetic SNPs. I run genetic testing through LiveCode GX with all my ALS patients, and I've been mapping since the start what I'm seeing, because as you know, I've got that little research head on me, so I really can't help myself. And I'm seeing a lot of patterns in methylation, particularly around the FUT2 genes and B12 pathways, which ties in a lot, actually, interestingly, with some research coming out of Asia showing really high dose injected B12 having a positive effect on people with ALS. I've tried to find the researchers because I want to ask them if they've done any genetic testing to see if the people that benefited were downregulated in those genes. I'm also, and what my master's dissertation will be on, so I'll have to come back and tell you all about it, is the choline betaine pathway and the synthesis and conversion of choline being an essential factor in neurological health, precursor to acetylcholine, cell membrane component in phosphatidylcholine, which converts onwards to phosphatidylserine. Also an essential component of bile, which of course is how the liver removes toxins from the body. And then betaine, of course, loads of really important roles in the body, really undersung hero, helping cells manage and survive stress by maintaining cell volume and fluid balance. It's a methyl donor in the homocysteine to methionine pathway. Significant anti-inflammatory properties, combats oxidative stress. So seeing these massive down regulations in those genes is a clue for me as to what might also be going on, perhaps not directly, but indirectly. We also have quite an upregulated phase 1 and a downregulated intermediate phase, and then a downregulated phase 2 in the liver detoxification pathways, particularly sulfonation, glucuronidation, and glutathione pathways. So again, just staying on the liver, we know that those detoxification pathways are essential for the clearance of the debris from the body. So if we don't have optimal pathways, we're going to struggle to remove any potential invader. And there's a lot of research looking at the invaders in these conditions.
Yeah.
We have to consider the importance of bile and the key nutrients needed for that to happen.
Yeah. It feels like there's a huge degree of complexity. So you've got, like you've mentioned, a few key areas that I think you could broadly break this down into. You've got like environmental influences like pesticides you've mentioned, but also nutrition, and then you've got the genetic tendencies, and then the functional picture within the biology, and and this sort of big view of like, what is externally driving it, and then the, genetic predisposition and functional sort of outcomes is really interesting. And I guess that helps you understand like what is actionable from a lifestyle medicine and nutritional medicine, but also environmental medicine feels
Right.
really important here. So I'm just wondering, like upstream of that complexity within the biology of these illnesses, are there key things that we know could be contributing to the disease development and progression that are modifiable, like diet and lifestyle factors?
Yeah, absolutely. So just first of all, to just run through a few key things of what we are seeing, and then we can think about what is potentially triggering that. So
Cool.
inflammation we see, neuroinflammation, inflammation at a cellular level in the brain. We can't talk about inflammation without talking about the gut connection. And there's particularly quite a lot of research for that in Parkinson's disease. Constipation is the most common non-motor symptom of Parkinson's and is often seen many, many years before onset. And there is this quite well evidenced thought of Parkinson's being caused by some form of enteric neurotropic pathogen passing from the gut to the brain along the vagus nerve. There was research, retrospective research, that showed that a full truncal vagotomy, which we don't do anymore, thankfully, but was associated with a decreased risk for subsequent Parkinson's, which was the first indication that the vagus nerve might be critically involved. And it was actually, back in 2003, the Brack hypothesis. Brack was, there was Brack and Brack team who did research and hypothesized that Parkinson started in the gut, way before anyone else was thinking it. And that's then been supported by research showing folded alpha-synuclein in the gut and also in the olfactory system. And actually more recently there's been some research questioning whether it may also start in the kidney, but that's very new research. But there's been research throughout the last 15 years identifying alpha-synucleins in the colon tissue before the onset. And that corresponds actually with those early symptoms of loss of smell if we're seeing it in the olfactory system, and constipation. And there's consideration for a possible spread. So when we dig into that gut research and say, well, if gut inflammation is driving neuroinflammation, what's driving the gut inflammation? There's research considering small intestinal bacterial overgrowth. And actually, with Parkinson's, there's been quite a big focus on dissolvo vibrio, which is one of the bacteria thought to contribute to SIBO. And so there's been studies looking at eradicating SIBO, resulting in an improvement in motor fluctuations.
Mm-hmm.
We're seeing a bit of an imbalance as well, quite a few high levels of some of those gram negatives, the lipopolysaccharide releasing bacteria, and reduced Prevotella, increased calprotectin, so a marker of intestinal inflammation seen in people with Parkinson's, and also potentially low short chain fatty acid producers as well. And then, of course, we have the neuroinflammation, which is a key driver. So damaged neurons release danger signals, DAMPs, which instigates an immune response and perpetuates inflammation. And we see activated microglia and astrocytes, and they're releasing these pro-inflammatory cytokines. And so a feature of Parkinson's is this chronic immune activation, which is linked to the alpha-synuclein pathology and the mitochondria not functioning properly. And recently for ALS, there's been a lot of research considering the impact of interleukin-6, a pro-inflammatory cytokine that's been found to play a significant role in progression and pathology. So there's a lot of eyes on that at the moment as well for some research. Higher IL-6 concentrations have been linked to more rapid functional decline and worse clinical outcomes. So it's a big area of research. I know that I just had to submit a 3,000 word assessment.
Well, I'm glad we got the summary.
oxidative stress, of course, and then you've got that cycle, haven't you? Because you've got oxidative stress causing mitochondrial dysfunction causing oxidative stress, and that wheel just keeps on turning.
It feels like quite an integral part of the pathophysiology is that mitochondrial dysfunction, oxidative stress. In fact, some of the drug treatments target that, right?
Yeah, absolutely. So first of all, particularly for those with like the SOD1 genes, or the genes that are related directly to higher oxidative stress, but also there's a lot of research around excitotoxicity coming from glutamate, with an excessive glutamate receptor stimulation that's causing this influx of calcium, leading to mitochondrial damage, and particularly in ALS and motor neurons, that people are particularly sensitive to this calcium overload, so that can enhance vulnerability, triggers cell death. And so again, we've got to think, well, why is that happening? What can we do from a nutritional medicine standpoint to reduce the glutamate receptor stimulation? But some of the main medications on the market currently are actually very much targeted on the glutamate toxicity.
Mm-hmm.
So,
yeah, like as I'm hearing you speak, these feel like, for people who understand functional nutrition, it's like, oxidative stress, glutamate release, I should say. Like these feel like things that are modifiable via diet and nutrients. And we have like experimental observation, and clinical evidence to show that. So I'm just wondering, like, is anyone looking at this in the field? Like a nutritional interventions getting any traction?
not as much as, the drive currently in most academic institutes, of course, is to find a gene therapy, but that only helps a maximum 10% of people. So Dr. Richard Bedlack, who I'll talk about in a while, he runs something called ALS Untangles, and publishes papers on research coming in on all sorts of supplements and such, and I'll come to his work. So there is stuff going on in the field, but unfortunately, there's always so much funding to try and come up with a drug, and I'm sort of there at the university going, but we can help mitochondria through diet, and everyone's just like, let's get another study going, and I'm like, oh. And yeah, mitochondria dysfunction is, if you think about it, every cell in the body has mitochondria, usually 2,000 to 3,000, but some of our neurons have up to 2 million, and they are really long. They're like a meter in length. And so that tells you a lot about the job of a motor neuron. It is to send an impulse to create movement. And when we see in people with ALS, it's almost like the battery is stopping working at the far extremity and working up in people with the lower limb ALS. And you can almost see that it's the mitochondria. They just don't have the energy to sort of send that message. And there's a lot of research going on considering what's going on with mitochondria. So, that mitophagy isn't happening. Mitochondria aren't repairing themselves. The fission fusion of mitochondria perhaps isn't happening. There's an inability to clear the oxidative stress, particularly in the inner membrane where the complex is, which is where a lot of the oxidative stress occurs. But again, we've got to say why is this happening?
Mm-hmm.
So there was a lot of research looking at the cytoskeleton in the cells, the microtubules. In each cell there's just this whole network of little roads, microtubules, and molecules walk along them and deliver various things in the cell. So, what's blocking those roads? That's a big area of research at the moment. We know some toxins can block microtubules, so that's a consideration. And then what's quite big at the moment is the cell danger response.
Mm-hmm.
So, Bruce Hoffman is doing some amazing training on this at the moment for anyone really interested. But, physical and emotional factors send warnings to all of our cells. And what then happens is the mitochondria they just sort of have this protective mechanism where they will almost just close the doors and shield themselves, from further harm. And so we're considering that as well. We're seeing mitochondria just not producing energy, and the threats can be infections, toxins, physical injury, psychological stresses, that and they impact the cell's ability to maintain homeostasis. Like I said, the mitochondria almost just go, well, we're not producing energy to fund what's going on out there. But of course, if you can't then reboot that, that's when we see chronic illness.
Mhm.
And then, so, what's driving it, I suppose, is the big question, right?
Yeah, yeah, absolutely. Yeah. Yeah, and it feels like like I said, a lot of these things do upstream are likely to have, an interaction with environmental, lifestyle, and dietary factors. And I know there certainly is some work in this area looking at from a more, I guess, functional perspective, targeting things like the mitochondria, B vitamin metabolism, the microbiome. There is emerging work in this field, right, for nutritional medicine.
Yeah, I have to say, working with ALS, as soon as you hear the word ALS, there's this sort of feeling of slight panic in most health professionals. So I actually ignore the diagnosis because it really is just a word for a presentation of symptoms
Mhm.
and um, and markers, right? So I strip it back the way anyone would working in this field, and it's like, okay, let's take the systems-based approach. So what's going on with the gut? Let's ignore all of that. What's going on in the gut? Because if your gut isn't functioning, you're not going to be able to absorb any of the supplements and nutrients I'm trying to put in your system. And inflammation is going to remain up. So again, going back to that long list of things, there's inflammation. What can I do that's anti-inflammation? There's oxidation. What can I do that's antioxidation? The mitochondria aren't functioning. What can I do to support the mitochondria? And the liver's potentially not functioning. What can I do to support that? And it's really taking that approach just one system at a time and just trying to methodically, strategically, slowly, because if you work too quickly with people with motor neuron disease, they can decline quickly. I've had so many people come to me that have gone to someone and they've said, I know what's wrong with you. Here's a ton of binders and some chelators, and they've nose dived. So it's all about slow, methodical, using a really evidence-based, systems-based approach.
I mean, that's beautifully put. And I think that really speaks to the essence of, integrated functional nutrition or functional medicine, whatever you want to call it. But it's that personalized systems biology based approach that I like the way you put it. It's quite provocative. It's like you get rid of that diagnosis because it clouds, it's not helpful at the end of the day, other than just identifying a particular drug, maybe. But for this kind of work, it needs to be much more nuanced and individualized. So you're looking at different areas of dysfunction, personalizing interventions, and almost teasing out different disease subtypes because these are heterogeneous disorders that the title tells you broadly what the symptomology and pathophysiology might be, but it doesn't tell you what's going on for that individual. And I'm assuming, I mean, you're more the expert, but I'm assuming in these disorders, you don't see the same presentation all the time, physiologically or clinically. It varies quite a bit.
Does, and I'll come on to some of the tests that I run, but there's so many things in the literature that are linked to this. So if we just run through some of those environmental factors, because when it comes to Parkinson's disease, it's actually, there's more and more research all of the time that this is almost like a man-made condition, which I'm sure a lot of people will be like, what did she say? But there's a book actually coming out today that I cannot wait to read by Dr. Ray Dorsey called The Parkinson Plan, which focuses all on the environmental factors. But these have been well noted going back in the literature. When I first started looking at Parkinson's with my own symptoms, I was like, how are the papers going back to the 80s on this and no one is doing anything?
Yeah.
It's crazy. um, Persistent organic pollutants, so POPs, hazardous chemicals. So that's your pesticides, industrial chemicals, your PCBs, dieldrin, heptachlor, dioxins, all cause serious health problems, including neurological damage. There was a research paper that came out a few years ago showing that over the last 25 years, Parkinson's rates have increased 22% globally and 116% in China, which is also the fastest industrialized country, fastest growing industrialized country. There's been research showing correlations of pesticide use in rates of Parkinson's disease in France, Canada, and parts of the US. And of course, exposure can be through air exposure, drinking water, particularly if you have a well, soil contamination, and foods. The first sort of understanding that there might be this chemical link was actually in 1982 when somebody presented with like sudden onset end stage Parkinson's in an emergency room in California, and they'd taken heroin, and the heroin had been laced with something called MPTP, and that becomes something called MPP plus that damages the substantia nigra. And it was the first sort of, oh wait, there might be a fact here.
Like chemically induced, yeah.
Yeah, rotadone, Paraquat, DDT, Agent Orange. Veterans are disproportionately suffer from these conditions, ALS and Parkinson's. Industrial solvents, so like TCE, which you'll find in paint strippers, paint removers, adhesives, cleaning fluids, things that a lot of us have in our homes, and glyphosate.
Just a quick question on that. Like these things are pretty ubiquitous in the environment. Do you think previous exposure is necessary for them to play a role in an individual? Like, or could they be a factor for anyone?
Well, so what the research has sort of shown is, so for example, there was one study that showed that farmers are 170% more likely to develop Parkinson's than non-farmers.
Wow.
The longer you work with pesticides, the greater the risk. What's been quite interesting, just in May this year, putting Parkinson's back on the map with pesticides was this study that came out of Rochester in the US, the Rochester Epidemiology Project, that found a link between living near golf courses and this massively like 120% increase in risk of Parkinson's, which was really quite damning. And actually people working as groundsmen or working in these environments, because golf courses are more sprayed than any other ground, so
yeah,
you have to consider that.
yeah.
Metals, very much linked as well, cadmium, other metals, lead, mercury, all of the thallium, all of the sort of usual suspects.
Yeah.
I see a lot of gadolinium in my patients' results, and it's one of those questionable things, gadolinium deposition disease, but it's definitely something that I think we should be considering.
Mm-hmm.
Yeah, so lots and lots and lots of potential exposures from metals and pesticides and or organic pollutants, but also molds, candida, viruses, all factors as well. But with those, for me, I'm like, well, is the mold and candida and viruses present because the host is weakened because of the toxins, or are they a driving factor, or are they both? So that's something as well I'd love to see more research on, because there's big focuses, there's high viral loads. Well, of course there'll be high viral loads. Anyone who is immunocompromised, virus is like straight in there.
That's right, yeah.
Definite links in the literature to certain members of the herpes family, and a few other viruses as well linked.
Mm-hmm. And speaking to like host resilience to things like toxins and viruses and so on, are there any clues, like from observational and epidemiological work, to suggest nutrients play a role in resistance to these diseases?
So there's definitely a lot of research in the Parkinson's world around diets that can be preventative, protective roles, particularly around Mediterranean diet, mind diet, are the two sort of most researched there. Keto diet is coming up the rear, but mostly in animal studies still. And, we've got some small human studies and we do need more. But, I mean, sense says absolutely, right?
Yeah.
Like, sense says that if we're talking oxidation and we want antioxidants, what are the antioxidants? Vitamin A, C, E, selenium, zinc, PQQ, CoQ10, alpha lipoic acid. And where do we get them? We get them in the diet, right? So
Yeah.
we want to make sure that we're supporting that. When we're talking about inflammation, how do we reduce inflammation? Well, it's the anti-inflammatories. How do we support liver health? Well, we know of all the nutrients, all of those antioxidants, all of those anti-inflammatories, certain proteins. I have to say that your paper, yours and Deanna's paper from 2019 is my most quoted paper because of glutathione dysfunction and the need for glutathione. So a lot of my supplement protocols are based around that paper in terms of dosage, because, again, we know that glutathione is essential. So what can we do to increase glutathione levels in the body and really support the liver?
Yeah, that makes sense. And I guess you could even extend that into glutamate signaling, is that if you have deficiencies in something like magnesium, for example, it could, result in excessive signaling that would form part of the picture. Yeah.
That's exactly it. So, all my clients are on high dose magnesium just because fasciculations are cramps, aches, pains, sleep dysfunction are all part of the condition. But it is that magnesium will sort of prevent glutamine converting to glutamate and help glutamate convert to glutamine. B6 as well, helping with the onward conversion to GABA. There's things we can really consider from a nutrient perspective when we start really thinking about this as therapeutic nutritional medicine, which is my preferred term. When I'm talking to clients about what their diet should look like, and we'll come on to the need for calories, but completely antioxidant, gut supporting, immune supporting, mitochondria supporting, high fat to really replenish cellular and mitochondrial membranes. And so when we look at the research, so there was a paper that came out just this week, actually, from a university in Korea. Dale Bredesen posted it. So I was just reading it yesterday, which was about which diets are seemingly the most effective for Alzheimer's. And again, it comes back to the MIND diet and the Medi diet and a couple of other more recently developed eating scales. But when I'm putting together a diet based on my knowledge and what I know of these conditions, Dale Bredesen's Keto Flex or the ketotarian sort of way of eating, which is Dr. Will Cole's model, I would say is where I draw the most inspiration from, because it's what makes the most sense to me.
Mm-hmm.
I want a diet that has no toxins in it. It's organic and clean, high fat, moderate amount of protein, relatively low carb, making sure that every mouthful of food is highly nutritious. So the carbs that don't really offer much in the way of nutrition are removed and replaced with other carbs that really do offer nutrition. There's a bit of a difficulty there because I would love to do intermittent fasting with my clients, but at the same time, I've got to be really careful about weight loss.
Yeah.
In class. And I am a huge Deanna fan, so I'm a big promoter of the rainbow of color with all my patients as well, because I don't see the point in telling people to strip everything out and eat meat only and then take a capsule of resveratrol and a capsule of quercetin and a capsule of PQQ when they're things that we can get in a really well-rounded, balanced diet.
Yeah, that makes a lot of sense. And I think what would be good to do is jump into a few layers of specifics around clinical management. But before we do that, I'm just curious, what are you seeing clinically with this kind of approach? Are you really focused on improving quality of life, improving function. Is it possible that there's some, slowing or even reversal of the progression of the illness? I mean, would we anticipate with this kind of functional integrative approach?
Yeah, that's a really good question. And anytime you log on to anything, whether it's MND Association, ALS Association, and these associations do fantastic work. They provide a huge amount of support to patients. So it's with no disrespect to them, but every article you read starts with this whole paragraph, which is like, this is incurable. People will die in X time. And it's like, you don't have to say that over and over again. The people that have this condition are well aware of their prognosis, and they're well aware that there are no supportive conventional therapies beyond medications that may provide an extra month or two of life, right? So I don't know. I was always the kid that was a real science geek and also just loved a puzzle. And I think there's lots of things that were incurable 10 years ago that are now very much curable.
Yeah.
So for me, do I feel that ALS can be reversed? The answer is yes, and I'll explain why. So first of all, I think the easiest thing for any health professional to say is nothing can be done. It's the easiest sentence. It sort of provides us with no pressure to do any research, any extra work, any digging. It's really important not to give false hope. So we have to find the balance. But I'm a big believer that there's always something that can be done, even if it's just improving quality of life, improving gut health so people aren't chronically constipated and feeling terrible or having horrendous diarrhea or stomach pain or bloating, reducing the saliva and mucus that a lot of people get, which in itself can extend outcome, reducing itchy skin, improving immune health so there's less susceptibility to illness, supporting energy levels. Nutritional medicine is a really powerful tool. And I strongly believe that there is a root cause to all physiological dysfunction. So if we can find the root cause, and I think it's very different in everyone, and remedy it, and if the physiological damage isn't too excessive, then I do believe that to a degree, maybe not fully, but to a degree, the body can heal. So my goal with my clients is to slow decline if I can. I don't, I try to optimize health status. The only promise I make to my clients is that I am 100% in and will be 100% in it with them as long as they want to be in it to try.
Mm-hmm.
I mean, you can't promise more than that. But my goal is to try to slow decline or even plateau if I can.
Yeah.
And decline is measured using a score called the ALS-FRSR score. And at the higher end is a score of 48. And typically it's expected that people will lose a point each month, so 12 points a year. Now, what I also want to say is this isn't all in my head. Dr. Richard Bedlack at Duke University, an Ivy League school, has 60 confirmed reversals of ALS, and his protocol is so stringent. Like you almost have to be heading towards end of life and then fully better to be considered as one of his reversals. You have to have had all of the correct diagnostic tests. And there has to be very, very clear evidence, because he's a neurologist and a neuroscientist at Duke. So everything he does is incredibly stringent, and he has documented reversals. And then on a lesser note, so at the Healing ALS, we keep a monthly registry, and participants fill it out every month. And last year we just thought, well, let's have a look at it and see what people are highlighting each month in their ALS-FRSR score. And what we saw was people reporting improved functionality in about 20% of cases, stabilized in 20%, and 20% only losing 1 to 4 points over the year, where the average score is 12. Now, it's not a, it's not a randomized control trial, or double-blind trial. It's just an observational piece of research looking at what people are completing. But what it is it's almost a covert study. So no one's being told what to say. We're just looking at the data they've put in. And the average loss was about 0.3 points per month, which, compared to a
1
point
point.
is quite significant. And actually, we've just got our academic everything signed off in the US to run an official study. So I think it's a case of watch this space. But again, we have to be careful with the language. We have to be careful with what we're promising people.
Yeah. I mean, that is really well put, and I think backing that optimism up with the validation that there is some support that this kind of thinking or approach moves beyond resigning to the fact that it's incurable and we don't have any options, to actually looking a bit deeper, looking at the individual, looking at function, and and with emerging evidence to suggest we may be able to plateau or even reduce the typical decline is pretty incredible. And I think it speaks a lot to what the systems biology approach is all about. And I will say something completely inappropriate, but I heard Jeff Bland say once that one of the wonderful things about functional medicine, to paraphrase, is that we can reproduce miracles clinically. And that statement always stuck with me because it resonates with what you've just said, is that there's an inherent approach to this that writes off the illness as incurable. We've seen that change in other illnesses before, and we're seeing emerging evidence in this field now to suggest that there should be a sense of optimism and hope with a different approach to this. So it's a really powerful statement. I really appreciate you sharing that.
I think for me, I'd like to see the statement of that there's nothing that can be done changed, that whole narrative changed in conventional medicine to, I have no tools in my toolkit. Perhaps other people have tools.
Yeah.
At the same time, like I said, there's some organizations out there making big promises, and these are very vulnerable people. And I always know when something's gone out on all of the forums, because I've now got probably 50 ALS patients in my clinic, and I'll get like 50 emails saying, should I be taking this? I'm like, no, no. Sometimes they're unfounded, sometimes they are outright dangerous.
Yeah.
So I do wish that side of things was a bit more governed too. But I'm really hoping, and I know that the team at Healing ALS are hoping we can do more and more to blend conventional and functional and evidence everything that we're recommending, and help people to feel supported. And actually, one thing that has come up is the importance of hope and the importance of positivity as a healing agent in reversals. So we definitely need to consider that.
Yeah, and change that narrative. That's a really good piece of food for thought for people. So I want to talk through just some of the elements of clinical management. I've got like 3 key areas. One of them is the malnutrition, energy deficit piece, then this individualized systems approach that you've mentioned, and then just broadly lifestyle, environmental sort of considerations. So can we just touch briefly on the malnutrition piece? It's a really important part of care, and what are the key considerations around that?
Yeah, so ALS is a hypermetabolic condition. So meaning that if someone's energy out is 1,500 calories and they're taking 1,500 calories in, they're going to lose weight. So one of the first things I do with my clients is get them to sign up for Chronometer and enter what they're eating and drinking. And we don't focus on the micronutrients initially. The main focus is on the macro balance. If people are eating a really high carb diet, and by the way, there is also some research out there supporting high glycemic index diets for ALS. That's not my approach, but it's an approach, and if I have clients that are vegetarian, then we will be on a higher amount of carbohydrates. Again, for me, it's all about how nutritious it is. But I typically look at those macros first. If I make any changes, again, everything has to be low and slow in ALS. So it's just a very gradual move, raising the fat, lowering the carbs. But typically, if I want someone to maintain weight, I've got them eating 50% over their over their calorie needs. And if I want them to gain weight, I've got them on double their calorie needs. And that seems to work. I've managed to increase the weight in most of, not all, but in most of my clients, if they've followed my guidance. And that is really important because the research clearly shows that there's a very clear link. And the other thing is it's working with people, and people don't want to feel like they're taking a step down, but it's just encouraging people that if you're actually starting to lose the ability to swallow, or you're not able to gain weight, let's get that peg tube in, work with your dietitian, work with your family members, ensure that you're making peg feeds that are safe, and under the guidance of your MND team, that we can just get the nutrients into you, and just view it as a vessel for gaining nutrients. So yeah, that's weight loss. What's next on your list?
I guess the other piece, I mean, there's a lot attached to that, weight loss and cachexia, like immune dysfunction and so on. But what we might do is jump into that systems approach, so the individualized nutrition. And you've touched on a few really good examples that I think already speak to this, like the example of high dose B12, and then trying to understand why some people are responding, is it genetic, and so on, and that, the oxidative stress story. So can we maybe unpack some of those, like maybe starting with like basic nutritional deficiencies that may be affecting function and outcome and long-term survival and so on? Are there any key nutrients that stand out to be that you're screening for?
So we're screening for a lot. When people come in, because it's so multifaceted, I want to look at everything. And so typically a client comes into the clinic, the first thing we do is get a full blood panel. And when I say full, I mean, full metabolic panel, liver, kidney, full bloods, every nutrient that is worth testing in the blood, urinary iodine, which by the way is often deplete, and autoimmune markers, you name it. I've got a big list, inflammatory markers that get sent out. If we can't get it through primary healthcare practitioner, then we get it ordered. I want to look at that. I want to see what people's metabolic status is. We do see high metabolic dysfunction, but there's a big question mark around that, because I see high cholesterol even in patients that are eating a very clean diet. And actually, we know when mitochondria are breaking down and when neurons are breaking down, the cholesterol in the cell membranes is being released. So we're trying to understand, is metabolic dysfunction driving this, or is the breakdown of the neurons driving the metabolic dysfunction that we see in the markers? Because the easy thing to say is, oh, look, metabolic dysfunction, let's change the diet. But we've got to consider why those markers are where they're at. At the same time, I always run a methylation and detoxification panel, because I want to see how well people function genetically. Like, what are your predispositions? What are your weaknesses? Personally, I don't run anything like metabolomic testing till I've been working with someone for about 6 months, because if I run that test that's 600 pounds on day one, I know everything is going to be out of whack. So from the information we have, gut health is always first. So personally, and I know you'll agree with me on this, my preference is to not test the gut and to go by symptoms, because unlike the brain, that is like the teenager locked in a bedroom that will not tell you what's wrong, the gut is like the toddler who is like, I don't feel very well. So it's quite easy to tell what's wrong with the gut. Would you agree, as someone that like
That's such a good analogy.
I have on my shelf that I still use today? And so I think we can fix the gut. If we're not getting anywhere with the gut, I may then run a functional stool test. I'd rather save the money to spend elsewhere because ALS is a very expensive condition for people. Try and get the gut optimized, rerun any blood markers. So if every blood marker is low, then we know there's probably a malabsorption issue. So we may want to rerun those. Then move on to the liver. So what does the liver need? It needs milk thistle, pycnogenol, things, all ACE, zinc, copper, so checking the blood markers, checking that, going through those nutrigenomic tests. Where are the weaknesses? Let's plug those gaps, either with diet and or with nutrients. How are they with their immune system? Are they constantly sick? Should we get them on an antiviral like lysine or a higher dose of antioxidants just to try and help them to feel better?
Mm-hmm.
Then after all that, I'll typically consider a NutriVal or metabolomics test, just to throw out a very broad net with absolute understanding of the flaws of that test, but just to see what comes in. And then from there, if it looks like there's a lot of issues around the mitochondria, AONM are now doing this fantastic deep dive into mitochondria through a lab in Germany called MMD, and I'm obsessed. So I'm running that on everyone. The detail that test gives me to help me support these patients. And I'm plotting it because I'm seeing patterns that indicate cell danger response of like extracellular respiration and minimal respiration in the mitochondria. So I'll look at that. I actually have moved more towards bioresonance testing to look at a cellular response, and then I'll run other tests to compare that to as well. What I was finding is I was running bioresonance testing with NTA, someone who I highly respect, and I was running full bloods on viruses, everything, and bioresonance, without knowing what I was testing, was coming back as a complete mirror. So we typically start looking at that, try to understand what invaders are present. Are there metals? Are there molds? We see a lot of mold in these patients. And then how can we counter that? So then the very, very slow, very gentle approach to detoxification, which is, by the way, a word I hate in our world because you see it everywhere. We're going to detox. I'm like, your liver's detoxing 24/7. Like, I think we need to change that term. What I mean there is start the process of cleaning out things that might be affecting people at a cellular level by facilitating liver pathways, ensuring optimum bile, making sure the gut wall has full integrity so nothing can slip back through, gentle buffers, and then potentially a few very gentle binders just to try and catch anything that the body is releasing, but also making the body feel incredibly safe, bringing down cortisol, lots of grounding, lots of nature, lots of mindfulness, to try and bring down that cell danger response. That's a nutshell of what I do.
Yeah, I mean, there's so much to unpack there. It's like, it's a very top line view of a tremendous amount of detail that we could dig into, but we don't quite have time. I think one area I wouldn't mind teasing out a little bit more is more direct approaches to mitochondrial dysfunction. So you've mentioned a few things. One of them is a more lower carb ketogenic approach, which is arguably working on energy metabolism through the mitochondria, and you've touched on a few nutrients. Are there any standout things, or is it, I guess it's everything ultimately, but are there any targeted standout things that you find are working well to improve mitochondrial function in different clinical presentations?
Absolutely. I mean, so the research, especially with ALS, is showing a sort of a dysfunction of glucose metabolism at cellular levels. So I do personally feel, and that's coming through in the conventional literature, that's through my studies at Sheffield. This isn't, a quirky podcast I watched on a dark Tuesday evening. It's actually what I'm studying in my master's that we're actually seeing this. And so there's the usual suspects, the complement system can't function without CoQ10. So we have to make sure we're optimizing that. You can't utilize fats for energy if you don't have carnitine. Betaine helps carnitine. So particularly important if I'm working with someone who's vegetarian for a lot of these nutrients. Fats. I say to my clients, I want you to take pumpkin seed full of magnesium. I want you to take sunflower seed full of choline. I want you to take flax and chia. I want you to whiz it down, and I want you to throw it on everything like you're throwing confetti at a wedding. Like, just, throw it on everything, because cell membranes are so dysfunctional in these conditions. And if you imagine a meter-long neuron with billions of mitochondria, I listened to a podcast on Max Leva's show that was talking about Parkinson's, and the speaker who I mentioned, whose book's coming out, said, think of it like a bin liner full of jelly beans. That's your motor neuron, and each jelly bean is a mitochondria, and that's so true. And each mitochondria has an outer fatty layer membrane and an inner membrane. They need fat. So yeah, as many essential fats as we can get in, really, really important. Choline supplementation, MCT supplementation, also helping to get the calories up.
Yeah, makes a lot of sense. So you're not just providing these sort of key nutrients that, have been studied and improve mitochondrial function and so on, but also thinking about structure function and the membrane composition through, lipid, replacement therapy, I think is the term Garth Nicholson called it. It's
That's definitely the way we're moving things, and focusing on with ALS for sure. And another one that I know you'd mentioned to me was creatine, and actually nearly all of my clients present with low creatinine, elevated creatinine kinase, and I find that supplementing with creatine helps to rebalance that. So another supplement called HMB, which is hydroxyl methyl butyrate. And there was a really nice umbrella study. I love an umbrella study that came out just last year, demonstrating that HMB with people with muscular atrophy can actually help to improve muscle strength. So I typically use a creatine HMB supplement. Also, it takes pressure off the methylation pathways, making sure everyone's got optimum amino acids. You can't do much in life without the right proteins. Obviously, there's certain ones we don't really want to overdo, but the sort of key components of bile, the key components of glutathione, of energy pathways, and liver detoxification pathways we really want to focus on. And then I suppose curcumin, resveratrol, B1, all really essential for mitochondrial function.
Yeah, makes sense.
Acid, hugely researched for mitochondrial function. One tiny study on rats considered the potential of alpha lipoic acid pulling mercury into the cells. So that went out of the forums, and now all my clients are terrified of ALA, and I'm like, so we only use it when people have removed all of their amalgams.
Okay, interesting. I wasn't aware of that. That's fascinating. And then broadly, they're nitty-gritty nutritional interventions. Are there anything that really stands out in terms of lifestyle and environmental changes? I mean, you've mentioned exposure to pollutants. Is that something we can even begin to address in people's environments?
Yeah, absolutely. So one of the first things we actually do at Healing ALS, so the Healing ALS program is 47 steps. So it's a really intensive program, and we keep sort of editing it. It's constantly updated. And is it perfect? No, but we're really working on it. So the first steps, once you get past sort of, support your mind, make sure you've got your team, is clean home, environmental factors in the home. So cleaning products, personal care products, all of that, just out with anything that is bringing toxin. If you are a bath and your bath is full, this is Dr. Cowden's analogy, we want to pull the plugs out the bath, but if you're still pouring water into the bath, then we're not going to be able to empty the bath at all. You're still going to be flowing over and seeing these symptoms. Air, so making sure that air is clean, making sure the water is clean with filters, especially anyone with well water, and especially in places like the US where, you know, there's perhaps in certain areas been unlawful drainage into soil that can then sweep across. Organic foods, so making sure anything we're eating and drinking, anything that's going into us, on us, in our skin, in our throats, you know, you name it, like cleaning all of that out is really important. EMFs, so where possible, just really reducing your exposure, not having phone on charge next to you when you sleep, turning the Wi-Fi off at night, which is really hard for people that are heavily dependent on others. And a phone has sort of become a bit of a lifeline. And I don't know about you, but I'm terrible. I walk around with my phone even when I'm walking around the house. I'm like, what am I doing? Just put your phone down.
Yeah.
It's just become synonymous with life. Everything is about cortisol. When our cortisol is high, we have immune dysfunction, we have neurotransmitter dysfunction, we have metabolic dysfunction, our circadian rhythm is dysfunctional, we're not producing enough melatonin, our sleep is impacted. So anything to sort of clear the mind would be really great. Dental health, making sure there's no infections anywhere that have closed in, making sure that there's no leaking amalgams, and if there are amalgams that they're removed safely, just to reduce toxic load. Yeah, lots and lots you can do to clean your world.
Yeah, no, that makes a lot of sense. So really talking about an approach that's very, you know, it's not just personalized, it's very like multi-component, multi-dimensional, and extremely holistic. Basically, you're looking at lifestyle, environment, you know, considering a lot of different modifiable factors across the way people are managed.
Absolutely.
Yeah.
And mold. You know, we see this. In fact, when I first joined Healing ALS, which was quite a while ago now, and I was chatting to Tish, who set this up, you know, they set it up as really they were documenting reversals, and it just built from there. That was how it's set up, and it's a not-for-profit, you know, so anyone can go on there and get free support, and it's a really great program. But when I first spoke to Tish, and I said, you've been doing this now for a really long time, what do you see? And she said, mold and trauma. There's also Lyme, you know, Lyme disease is a definite potential differential with this. It presents in the same way. Gadolinium presents in the same way. So, you know, we've got to also make sure, and people will always say, oh, well, if there's been reversals, they must have been a misdiagnosis. And I'm like, great. That means there must be so many people out there with a misdiagnosis. How about we help those people who have been told they've got ALS, but they've been misdiagnosed?
Yeah.
So you can't say to me that we've done a study with 45 people, 60% to 85% have seen a slower decline compared to people following a conventional program, and all of ours were misdiagnosed, and none of these were, you know, it makes sense.
Yeah. And it speaks to the comment you made earlier, is that the approach to this is to throw away the diagnosis and look at what's going on in the individual. It's the same thing.
What's going on?
Yeah. Yeah, I think we're going to have to draw to a close. You know, we could go on for a long time. There's been so much interesting information here. Really appreciate your time in painting a picture for what's going on and taking listeners into a real deep dive into this area. And I think for me, some of the real takeaways are that, you know, rather than looking at these as incurable degenerative illnesses that have a really poor prognosis, there is hope. There should be a sense of optimism within all of this, and that is hope that's based on evidence and credibility and emerging thoughts in this area. That it's not just a a disordered neuron that needs a drug. It's a person that has a complex heterogeneous disorder that has different types of dysfunction that could be addressed. So I really want to commend you for the work that you're doing, and that message for people, I think, is really important and empowering. Maybe this whole area needs to change, this narrative around these illnesses, the way they're thought about and managed.
I agree. And I think, when we think about how we work with these clients, people ask me about it, other practitioners, people potentially considering coming into the field, as I said, I've got Kerry working with me, and there's potentially scope as I work through this to kind of expand. But I always say to people, like, if you're working with ALS, you are working with people who have been given no other positivity. Everything else is palliative. And so it's not the kind of role where you can take a few weeks to get back to a client, or just make little flyaway comments, or take whole summers off and come back to the clinic. It's you've got to be all in. You've got to be continually willing to read the research. You've got to be constantly looking at every system. You've really got to be willing to look at immune health, metabolic health, gut health, across the board. And you have to hold the responsibility of working with these people with such respect. There's a huge pressure and a huge sense of responsibility that comes with what we do. So we have in our clinic, we have like a WhatsApp group for the patients, and a WhatsApp group for their carers. And then we have the wider Healing ALS group, which offers support. Ray, my office manager, is also like a breathwork and movement practitioner. We offer like a Wednesday breathing for healing session for everyone for free. It's, we're trying to sort of create a nurturing space where any of my patients can reach out to me any day of the week, and they know they'll get an answer if they're struggling. And I think if people are like, oh, this sounds really interesting, definitely think about whether you feel you can offer that.
Yeah, no, I get that. It's not an easy area to work in, and I think what you're doing here is with that difficulty, building something that meets people in that difficulty. So there's a very high level of care and support, and it's incredible to hear that you're building those communities. It's not just a one-on-one practice, is it? It's there are multiple practitioners in your practice, and you've got systems in place to support these people in a way that meets them there. It's incredible.
I hope so. I hope that's what we're delivering. It's what I set out to do.
Yeah, no, it's really powerful. And, on behalf of the listeners, I, want to again just commend you on the incredible work that you're doing in the field. It's hugely important in an area that, in particular, really needs that level of commitment. So, thanks for being the pioneer, and also thanks for taking the time to walk us through this and give us your perspective. It's been tremendously insightful and valuable.
Thank you so much for having me, Ben. I really appreciate it.
Pleasure.